Goodman, our nursing educator manager. We are delighted you can join us tonight for a CME program on measles. Uh, this program tonight provides Category 1 CME credit, 1 hour for physicians, and 1 hour of Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern States CME Collaborative for Category 1 Physician AMA CME and is accredited by the Virginia Nurses Association for providing nursing CE credit. The program this evening was developed to promote two desirable physician attributes, that is, of our providing patient-centered care and employing evidence-based medicine. Dr. Donowitz, our speaker, myself, and members of the Sovah Health CME Committee have no commercial relationships to disclose to the group. There is no commercial support for the program this evening. The program this evening, along with all of our CME activities, is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis established this fund upon his retirement in 1985, and it's been able to grow and provide an endowment for us to support speakers for our CME programs, as well as those for all other healthcare professionals here in Southside, Virginia. The program system will send you an evaluation form at the end of the program, and you will be shown in a few minutes basically a QR code you can click on if you want to download and go to the evaluation form that way. We very much appreciate you taking the few minutes that's required to complete the form. It helps us a great deal in program evaluation and in developing future programs. When you receive that request for the evaluation form, it will ask you again for your name and email. Please give us your full name because the name you give us is what will appear on your CME certificate. So please no nicknames, short names. Please have it in the name that you would like your certificate to read. If someone is sharing your logon, they are more than welcome this evening. We're delighted to have all people who want to learn with us. But if that is the case, please let us know so we can give credit to that person also. The QR code for getting to the eval form, if you like that method of doing this, will appear in the chat box towards the end of the program on Teams. I'd like to remind the residents, and this evening we're welcoming our new class of internal medicine and family medicine residents. These 16 new individuals have just begun their respective residency training this month. So they know, and the other residents on the call know, you do not need to keep up with the CME certificates for the residents. Your program coordinators, Dara Johnson and Lori Galvez, will track your participation for you. And to that end, a CME certificate will be emailed to you for the others who submit an eval form. Each time we do a program, I like to specifically thank Mary Kent, my CME coordinator, who does all the heavy lifting in the background to make our programs possible, and to Jennifer Goodman, who does similarly the work that's needed for nursing CE credit. If you have any questions about the evaluation, the program, etc., please reach out to one of us and we'll be glad to try to help you. Dr. Donowitz, I know, urges questions and then a reaction. It makes for a better learning experience. If you want to raise a question, we urge you to do that. You can raise your hand and or type it into chat, and Mary will get that around back to him. And if you do ask a question, we ask that once you've asked the question, please mute your phone so we don't get feedback. You can ask as many questions as you'd like or make comments. I want to briefly remind you of an upcoming program we're having in only another 2 weeks. This is the first summer that I can remember we've done programs. The reason we did them in this month of July, and there will be some in August, is simply because we've had so many pressing topics that we felt just couldn't wait till the fall, such as the current, if you will, increased uptick of cases of measles. So we needed to talk about it now. So we will be having programs available in the rest of this month and in August. In 2 weeks on July 31st, we're delighted to have a program for which we've had many requests. And this is a presentation, a review of how patients make decisions on care they receive. And that'll be done by Molly Huffman, who is a world-class healthcare attorney for patient interest and rights. She's located in Richmond. She's taught for us before, a very good speaker. And the second talk is going to be about a review of what's specifically available for patient assistance programs in the Danville and Martinsville community. And Dr. Brittany Lewis, one of our senior family medicine residents, has spent a great deal of time this past academic year pulling these resources together. Carla Lipscomb, our case manager director, will be moderating that program. If you care for patients in any way, outpatient, inpatient, whatever, please be with us in 2 weeks. I think you'll really benefit from Ms. Huffman's discussion of how you determine capacity, that is, patients to be able to make a sound decision about their care, and then the resources that we have here in the area to which you can refer your patients. All that being said, it's my delight to have Dr. Jeffrey Donowitz with us this evening. He is faculty at both the University of Virginia in Charlottesville, as well as Virginia Commonwealth University in Richmond. He began his educational journey at Davidson College near Charlotte, North Carolina. If you're from North Carolina like I am, going and being accepted and completing a Davidson degree was a real academic accomplishment. It is a superb, smaller college in the Southeast, but turns out really, really capable folks. He received his MD degree from the St. George's University and then completed a pediatric residency at the Virginia Commonwealth University in Richmond. This was followed by pediatric infectious disease fellowship at VCU and then a second infectious disease fellowship, including international health research at the University of Virginia. And of course, he's faculty at both places. He's got 4 book chapters to his credit, numerous editorial board participation. And I think one of the most outstanding things he's doing currently is he's a major leader of the Pathogen Genomics Centers of Excellence Network. This involves multiple healthcare centers that are looking at innovative and technical ability to determine not only the epidemiology of various pathogens, but their genetic makeup, something that's so important currently. And then finally, he was recognized by the Richmond Magazine multiple years as what's known as the top doc in Richmond. So, Dr. Donowitz, we're delighted to have you. If you'll bring your slides up, mine should fall off, and the floor is yours. Thanks so much.
Let me unmute here. Dr. Moore, thank you so much for that kind introduction. And Mary, thank you so much for getting me all set up here. Let me just bring my slides up and I will get started. Right. All right. Can you guys see my screen here?
It looks great.
Looks great.
Perfect. So such a kind introduction. Thank you so much for having me, virtually to give this presentation. Welcome to everybody that's on the line. I was told that there would be various levels on the line, everybody from practicing physicians, practicing nurse practitioners, nurses, obviously the new house staff, a special welcome to them. I remember being a July intern. I still have nightmares about some of it, but you will make it through. And one of the most important things for everybody on the line, and what I teach my learners is the most important skill to practicing medicine in this day and age, is knowing what you know, knowing what you don't know, and calling folks when you don't know. And PEDS ID at UVA is here to help 24/7. So if you run into things, we're going to talk about measles, but if at 2 a.m. you need a hand with a measles case or anything else, we're on call. So we're going to talk a little bit today about, also, I'm very informal. If you have a question, Mary's monitoring the chat, but you can just unmute and interrupt me along the way. I'd rather answer things in real time. We can look at the slides if they're helpful and go from there. So we're going to talk about measles in the modern era, diagnosis, containment, and the hesitancy hurdle. I have no disclosures. Whoops, sorry. So the outline of tonight's presentation, we're going to talk about, measles. We're going to remember measles. We don't see a lot of it, but I'm worried we will. So we need to know the clinical features, the history, and the complications. We're going to review the vaccine and epidemiology of measles and sort of review the efficacy of this vaccine. We're going to talk a little bit about what to do if a fever and rash enters your clinic and what to do when you suspect measles. And then we're also going to talk about sort of how to come back from the brink and a little bit about vaccine hesitancy in the United States. I think, vaccination in children is something that a lot of you on the line are going to be dealing with in your practice, and you're going to run into vaccine hesitant people. And I think, we've learned a lot in the last 15 years about what's sort of driving vaccine hesitancy. And I think understanding some of those drivers can help you in those situations when you're the physician or clinician. So remember measles? It's an old-timey disease. I'm dating myself here, but this was long gone and out of memory, and I think that's part of the problem. So what's the natural history of measles, right? This is the sort of meat and potatoes of the disease we're talking about. It's got a rather long incubation, so it can be anywhere from 6 to 21 days. You get this sort of prodrome where it comes on looking like really anything else we see in routine sort of general peds clinic: fever, runny nose, conjunctivitis, cough, very non-specific. And when case burdens are low, certainly measles would not be the first thing that jumps into mind. But somewhere around day 4, as the kid starts to get better from that prodromal illness, the classic rash comes out. And that's usually when folks start to think of measles, is when they see that rash. And that's when the Koplik spots start to come out. And we'll sort of talk about those things here in a second. But the sort of clinical keys that should really trip you off to think about measles is this starts on the face and it spreads down and out. So if that's the natural history of this rash, starts on the cheeks and face, then the chest, and out to the arms and the extremities. Koplik spots are pathognomonic, and those are the little white spots you get in the buccal mucosa. Labs can sort of be all over the place. You can have thrombocytopenia, leukopenia, usually mild. 30% of these children can have diarrhea at presentation, which often sort of throws people for a loop. They're thinking, well, there's some diarrhea here, so it's probably not measles. But actually, a lot of these kids can have GI illness. 15% will have a concomitant bacterial otitis media. And it's contagious for many days, anytime from 4 days before the onset of rash. So really, when the prodrome starts, you're contagious until 4 days after the onset of rash. Which is why it's such a good bug at contagion, because this is spreading before people are ever thinking of it. And for those of you who are thinking about return to school and those guidelines, it's 4 days from the onset of rash. So the physical exam of measles, I think, everybody on the line, these are some sort of classic pictures, but really you should Google this, and you should be looking at a lot of pictures. The more pictures you can see, and in the more skin tones you see those pictures, the better. The medical literature is sort of fraught with pictures of white people. And so when it comes to exanthems, really looking at different skin tones is going to help you. And those pictures are available on the CDC website, as well as others. This is a picture here of the Koplik spots. In the top left, you can see that they really look like these sort of white ulcerations in the buccal mucosa there. And usually there's multiple, so it's not one big aphthous ulcer or something. It's these little white spots that sort of have a hyperemic base to them. And then the classic sort of measles rash shown in the other slides. It can coalesce in places, especially on the face, as shown in the one picture in the bottom left. But if you've ever seen the rash, it's marked. It's not a subtle thing. So let's talk about the physical exam. Not every kid gets every symptom of every disease, right? And that was one of the things that I found hard as a learner, when you would read the textbook and it would list 12 symptoms for every infection, and then I saw these things in real life and I'm saying, well, it had like 2 of those, and so really, what can you rely on? So in the dark blue are measles cases after getting 2 doses of the vaccine. Now, the vaccine is 90% effective after 2 doses. So 97% effective, excuse me. So, much lower numbers there, but just to look. So the maculopapular rash, doesn't matter if you're vaccinated or not, all the kids are going to get that with measles. The fever, the vast majority who are either unvaccinated or only have 1 dose are going to get fever. Cough, again, very high percentage with cough. Coryza, very high percentage. Conjunctivitis, very high if you're unvaccinated, but you start to drop off. So the majority of cases you'll see are in unvaccinated. And so, in an unvaccinated child, you can really count on the fact that you're going to get a rash and fever, and then you are probably going to have all 3, cough, conjunctivitis, and coryza, the 3 C's of this illness. If you're missing one, certainly that could be the case, but they're pretty reliable markers of that's what you're dealing with, or not dealing with, for that matter. So, generally measles is a mild illness. It's, cough, conjunctivitis, coryza, and then you get a rash and you get better. But about 30% of cases, which is pretty high for viral infections, end up with a complication. The most common complication is bacterial superimposed pneumonia, and that's about 20% of the people. 1 in 5, so again, about 20%, require hospitalization for the unvaccinated folks. The mortality of this is relatively high. This is overall mortality of measles. It is 1 to 3 per 1,000. That may seem like a lot, but when you think about all the other respiratory viruses out there, that's a pretty high number. Risk factors for severe disease include the children that are younger than 5, pregnant women, and really any sort of immunocompromised. Same sort of similar percentage, 1 to 3 in 1,000 are going to end up with encephalitis. Encephalitis itself brings a case fatality rate of about 15%, and permanent brain damage in 25%. So somewhere around 40% of the encephalitis cases are either going to have brain damage or be dead. Acute disseminated encephalomyelitis, ADEM, 1 in 1,000 cases, and carries a very high case fatality rate as well. And if you don't die from ADEM, ubiquitously kids have, some sort of residual defects. Very, very common. And then probably the rarest and the scariest, at least to me, complication of measles is SSPE, subacute sclerosing panencephalitis. This is most common in children who got the virus when they were under 2 years old. But overall, it's about 1 in 10,000 cases. And the way that this works is it's actually intellectual decline is what you first see 7 to 11 years after the illness. So these kids have done well, up through, sort of early childhood, middle school years, and then they really start to drop off on an intellectual decline that can be quite prominent and debilitating for those kids. Sort of a terrifying late complication of measles that people have forgotten about. So do we treat measles? So the WHO's current recommendation is that all pediatric cases of measles should be treated with vitamin A. So this is a quick look at where that recommendation comes from. And remember, the WHO is the World Health Organization. And so many of the kids that get measles worldwide are malnourished and vitamin A deficient when they get their illness. We see a lot less micronutrient deficiency in the US. So what the data showed, and this is a meta-analysis, so it's looked at several studies, and these big black diamonds are sort of, if you take all the studies and you mash them together in the meta-analysis, what we see is that there's improved outcomes in children under 2. That very clear that's true. The data is less convincing for children older than 2 years. But again, it probably depends on how vitamin A deficient the child was when they presented. And children less than 2 years get vitamin and micronutrient deficiencies easier than older children. So the current recommendation, like I said, is to treat all children with suspected measles, but certainly treat any child you suspect of being vitamin A deficient. And so how what does vitamin A deficiency look like? Xerophthalma, Bitoad spots, and corneal ulcerations. And this picture here, this little white plaque in your eye, is what you get with a Bitoad spot. So if you get a child who is dropped off their growth curve or seems malnourished in any way to you, just as sort of a general malnourished assessment, that's child to make sure you treat. But certainly, the WHO recommendation is to treat any child, and the treatment is 2 doses on consecutive days. And if you have clinical suspicion of deficiency, repeat in a month. And the doses are up there in the top right corner, but those are published on Up to Date and other places like that. You can find those pretty easily. Other people you want to make sure you treat are those at risk for severe disease. So that's the young, the under 2 years, pregnant, and immunocompromised individuals. Immunoglobulin, some limited evidence in children who are malnourished, and especially those with clinical evidence of vitamin A deficiency, and certainly children who are severely immunocompromised, I would treat with immunoglobulin as well. So the sort of last clinical slide here, I get questions sometimes about various components of the MMR and rubella versus rubeola. So they're both measles. Rubella is German measles. Rubeola is measles. And sort of when we talk about these, there's some major clinical differences, but there's some similarities as well. So rubella, first of all, the R naught, and we're going to talk about R naught in a bit, is vastly different between these two. It's a measure of how contagious a virus is. Measles, one of the most contagious viruses we know. German measles, not that contagious. The incubation periods overlap. The common age group overlaps, primarily children. The fever tends to be much higher in true measles than in German measles. One of the similarities is a rash that starts on the face. And those rashes can look fairly similar, especially at the beginning when it's just on the face. Usually, rubella is sort of rash and fever, but you can get lymphadenopathy and you can get some joint pain. Again, duration of illness can be sort of similar. The complications are really what we need to know. Rubella has very few complications in children that get the disease. Kids do very well with it. It's not a big deal. However, congenital rubella syndrome is a really big deal. And in women who are not protected, really high rates of complications to the fetus, very teratogenic, and fetal loss and those type of things. And so that's why we vaccinate against rubella is to protect mothers and children in utero. And then both are the MMR vaccine is extremely effective in both. So before I sort of go into the next section, let me just take a quick pause. Any questions on the clinical side of measles? Okay. So epidemiology and the vaccine. You're going to come up against folks who feel they've done their research. And this is the picture that was showed to me years and years ago about folks who do their own research. So let's talk about transmission. The way that measles is transmitted is contact with an infected individual through respiratory secretions, cough and sneeze. So what makes this virus so contagious is that it's airborne. So it's the much smaller respiratory droplets, right? So big respiratory droplets, you cough and they drop to the ground within 6 feet of you and aren't floating in the air. Viruses that can live on smaller respiratory droplets can float around the air. And so this particular pathogen can stay airborne in a room for approximately 2 hours. So if somebody coughs, leaves the room, you walk in there 90 minutes later, you can inhale that virus. And it's so contagious that the small amount of virus that you inhaled is enough to make you sick. So we talk about R naught, and people, when we talk about measles, R naught comes up a lot. So R naught is the number of people that you would expect a single case to infect in a totally susceptible population. So in a totally unvaccinated population, if you took one case of measles and put it into that population, how many individuals would you expect to contract measles disease? And the answer is for measles, it's somewhere between 12 to 18. So you can see down at the bottom, the R naughts for some other sort of various pathogens, right? So pertussis, whooping cough, also very contagious. Chickenpox, highly contagious. HIV a little less. You get all the way down to things like Ebola, actually not that contagious. Now, highly mortal, but not particularly contagious when you compare it to measles. So the sort of estimation of what do you need for herd immunity, and herd immunity is the idea of how many people in a population, what percent of a population do you need vaccinated to halt transmission if a case were to enter that population? And that is really based on the R naught. So in order to do that calculation, you have to understand the R naught. So it may be, the calculation for herd immunity is very different for smallpox than it is for measles. So for measles, the herd immunity is somewhere between 92 to 95% vaccine coverage needed for herd immunity. And you can see in Virginia, as of the 2023-2024 school year, we're kind of right on that line, 94.2%. And you can see that there's some other states who are less than 90% there. And so those states are at risk of having sort of measles really start to spread within their communities. And remember, when we talk about herd immunity, the picture I'm showing you is on the state level, but really we should be thinking about this on the community level, because and on the city level, town level, and those type of things, because that's what we've seen in Texas and other places where despite there being pockets of high vaccine coverage, there's also pockets of extremely low vaccine coverage, and those are the communities where we've seen sort of sustained transmission, here within the last year in these outbreaks. So there have been 1,267 cases in the U.S. so far. That was as of last week when I sent my slides in. And you can see that sort of Texas is leading the show there with over 700 cases. But we've had 3 cases in Virginia so far this year. North Carolina, Tennessee, Kentucky, all have had cases so far this year. So it's here, and it's around. So the vaccine, it's a live attenuated vaccine. So remember, vaccines, we make vaccines different ways. So there's polysaccharide vaccines where you just take sort of one polysaccharide off the outside of the pathogen that is unique and specific to that pathogen. And if you inject that into somebody, their body makes antibody to that polysaccharide. There's protein vaccines, similar concept, but with a protein. And then there's killed vaccines. You just give the whole bug, but you've killed it. And then there's live attenuated vaccines, where we've taken an actual live organism, we've altered it such that it can't cause disease or rarely causes disease, or causes mild disease that we don't really care about, such in this case. And then that's what we infect people with. But the antibody that you make to that protects you from wild type measles. So you can see here that the vaccine was extremely effective. So, back in the 1960s, we were talking 500,000 cases a year in the US. And so, if you think about, things like our SSPE rates, that was something that you saw. And if you talk to infectious disease folks who, are my senior and were practicing in the 60s, yeah, they saw a lot of the encephalitis. They saw a lot of the, the bacterial pneumonias that killed kids and things like that. And then the vaccine was licensed in 63, and almost immediately we started to see just a massive decline in measles cases. But then there were sort of bumps, and we were seeing we really weren't as effective as we could be. So a second dose was recommended in 89, and then it was 2000 when elimination was declared in the US. And so one dose of the MMR is 93% effective. Two doses of the MMR after 1 year of age is 97% effective. So, are we back to where we started in terms of vaccination? No, we've had just over 1,200 cases this year. We are not at the hundreds of thousands of cases that we saw once upon a time, but we are certainly climbing. So let's talk about what the MMR can actually do, because the MMR has been blamed for lots and lots of things through the years. But let's talk about the truth of the matter here. The MMR is a live virus. You are being infected with the measles virus, just an attenuated strain. And so, it actually does have some it has more side effects than some of the other vaccines for that reason, as well as being, having two other pathogens in there. Fevers and feel bads, pretty common, 5 to 15%. And it can be up to 7 to 12 days later. It can last for 2 days, usually pretty mild. A measles-like rash is not uncommon. Up to 5% of kids are going to get a measles-looking rash. So if another clinical pearl, if you get called or a kid comes into your ER clinic, wherever, that looks like they have measles, ask them if they just got vaccinated. More than once, I've been on the phone with the ER in the middle of the night and have asked that question. And yes, they got their shots, 10 days ago. And you're going, okay, very good. Good night. Anaphylaxis, very rare. 3 to 10 per million. It happens immediately. So you anaphylax, within the hour. You don't anaphylax 6 days later, 7 days later. And there's been some people who have reported, oh, my measles caused me to anaphylax, weeks later. Febrile seizures, again, relatively common, not uncommon. 1 in 3,000, when you think about how many measles doses we're giving out, febrile seizures happen. But remember, febrile seizures are harmless. They're scary, and they're petrifying to parents. But a febrile seizure in and of itself is a harmless event. And it confers zero risk for subsequent epilepsy or seizures of any kind. And then transient thrombocytopenia, more rare, but also well documented. Generally, we never pick it up. It's transient, it's benign, we never see it. So, how did the MMR get such a bad name? And so this is a report in the Lancet in 1998, written by a guy by the name of Andrew Wakefield. So Andrew Wakefield did this study in 12 children, and sort of showed that he made this association between getting the MMR and getting autism. And this was based on again these sort of 12 children. It wasn't until 2010, based on some excellent journalism, that then sort of sparred a deeper investigation by the UK's sort of General Medical Council fitness to practice findings that sort of dug into this. They found out that Wakefield had done a bunch of things wrong in his research. So he had fabricated elements of these child's histories. He'd falsely obtained consent from them. He sort of collected these blood and colonoscopy samples that he had gotten because he showed measles was replicating in the gut, and then was causing inflammation and neuroinflammation based on this GI replication. But had collected these samples sort of unethically, and there's some question as to whether they were the samples of the children that he said they were. There was no real way to track back on that, but that was under question. And then he had accepted undisclosed payments from lawyers who were suing the vaccine manufacturers, and sort of that was pocket money for him. So this article was retracted, but really, it was out there for a good long time before it was retracted, and the damage was done. So since then, and based on this sort of controversy, the MMR vaccine has more rigorous science showing its safety than any other vaccine. Because on the heels of that Wakefield article, there were really strong studies where people tried to dig back and say, is that true? And then when it came out that he had fabricated his data, and it was basically a made up story, then it was really on to say, okay, do we see anything here that would sort of regain trust in this vaccine? And so, I think the medical community and certainly the scientific community at that point felt like the onus was on us to really prove or disprove this theory once and for all. Because the worst possible would be that we say he fabricated it, we do some science that shows it's safe, and come to find out, it really was linked to autism. Our credibility would, as a sort of medical community would have been hosed. And so this wasn't science done to prove that it worked. This was science done to reestablish credibility on the issue one way or another. So there are really two sentinel studies. This one was published in the Lancet. They were probably trying to make up for their sort of shoddy peer review years earlier. That's just a guess. But this looked at autism trends in 8 health districts from 79 to 1999. I did some of my training in the UK. Remember, they have the national health system there. And so, the researchers had records to really everybody in these districts' health records to go through. The MMR was introduced in 88, right in the middle of this study, and they showed really no increase in the slope of the line with the addition of MMR, meaning the incidence of autism is increasing, and we know that. And we think some of that is due to better diagnosis, but there's some signs that the actual incidence may be increasing more than just diagnosis. So the line was going up, but the slope didn't become vertical when the MMR was introduced. It was a consistent before and after. The next study published in the New England Journal, again, top journal in medicine, massive cohort, right? Over 500,000 kids, with 82% of them receiving the MMR. They looked at, 316 had a diagnosis of autism spectrum disorder or autistic disorder, with 422 were sort of on the autism spectrum. And when they adjusted for confounders, and even in unadjusted analysis, but even after adjusting for confounders, there was no increased risk of having a child who was diagnosed with autism or autism spectrum in the unvaccinated versus vaccinated group. They were equal between those two groups. So the 20% who were unvaccinated and the 80% who were vaccinated, equal risk for autism or autism spectrum. So let me stop there. And again, I'll ask, does anybody have questions at this point? Okay. So fever and a rash. What are you going to do when one of these kids walks into your clinic? So this is the WHO guideline. There are a bunch of guidelines. I'm going to walk you through them. I'm not going to read every word, but I want you to know where to find these things. And so, I believe my slides will be made available. If not, email me. I'm happy to send them to you. They all have, links at the bottom there. But the idea is, I want you to get the idea of these guidelines that I've cut and pasted in here. But really, the important part is I want to walk through them with you once, so that when you need to find them, you've seen them before. You can walk through them on your own. The idea here is if you have a clinically suspected case of measles, the patient is non-vaccinated, cough, coryza, conjunctivitis, Koplik spots, the rash, especially in the known context of a measles outbreak or travel. The idea is to collect samples, right? If there's any clinical warning signs of the things we care about, pneumonia, encephalitis, or vitamin A deficiency, that's a kid that's going to need inpatient admission. If not, you can probably take care of this kid on the outpatient, and usually it's a matter of just getting them some vitamin A and telling them to stay home. But often these kids don't need to be brought in, unless of course they're high risk, and high risk again is shown in that box in the bottom right. Younger kids, pregnant women, malnourished kids, and those with decreased cellular immunity. So now I'm jumping from the WHO to the VDH algorithms, and the VDH has a really good website that I encourage everyone on the line to explore for it's the Measles for Clinicians page. And it's got links to the guidelines that I'm going to walk through now. So really, according to VDH, and they will go through this with you if you send them samples. So they will reject your samples if they shouldn't be tested. But really, a patient needs to have all three: fever, the rash, and the rash can't be vesicular. That's the one thing this rash is not. So if you have all three of those things, then you're in the algorithm, and you go down here and you have to ask, does this child have an epidemiologic risk? So international travel, domestic travel to an area with a known measles transmission, Texas, or known exposure to measles. And if the answer is yes, call your local health department and let them guide you sort of from there. Again, if the answer is no, and the child is not, if the child's not vaccinated, look in the middle here. Have they gotten their MMR in the last 21 days? Then this is probably an MMR reaction. So what specimens are you going to be told to collect for measles? So the number one specimen is going to be a nasopharyngeal swab. So this is going to be sent for PCR. Highly sensitive, highly specific. You can use the same swab for both nostrils. The rest of the stuff on the BDH algorithm is going to be useful. Keep it refrigerated till it's ready to ship, those type of things. You can collect it in your kind of standard viral transport media. And you're going to always use a synthetic swab. So no, you can't really PCR off wooden swabs with cotton tips. So you're going to want plastic swabs with synthetic tips. Collect it as close to the onset as you can, ideally within the first 3 days of illness. But it stays positive for a good long time. So you sort of have 10 days after the onset of rash where this test is really picking up, genomic fragments. And so those linger, right? So DNA fragments linger even of dead virus, which is why you can dig up a body and test its DNA, 100 years later. DNA is very stable. So you can get a throat or oropharyngeal swab as well, but that's a secondary specimen. Urine, again, secondary specimen. Usually we don't collect urine really. And then serum for antibodies. So really what to do if measles is suspected in your clinic. First, try and keep this kid home. Measles that walks through your waiting room, or if you had what we had at UVA about a month ago, 5 weeks ago, which I was on call that weekend, so I handled the outbreak. We had one case that came through our ER, was in our ER for approximately 4 hours, was not put into a negative pressure room, and we had several hundred healthcare associated exposures, not to mention staff, patients, immunocompromised patients. It was a mess. So triage by phone if you can. If your practices at this point should be thinking up, for phone triage, ways to keep kids home. What are the questions to ask to keep kids home? If a kid has fever, rash, just had a runny nose and a cough, and all that is getting better, the cough is not worse, the fever hasn't, sort of done what a secondary bacterial infection does, which is the illness gets better and then comes back again with the cough, worsening cough and fever, then you could probably handle that patient without ever seeing them. Think about creative ways to see that child if you need to see that child, right? So can you see them in the car, in the parking lot, if you don't have a negative pressure room to put them in? Those type of things. And we certainly do that at UVA. We see them in the parking deck. Isolate the patient. If they're in your waiting room, get them out of your waiting room. Give the patient and the family medical or surgical masks, healthcare providers, N95s, gowns, gloves. If you have a negative pressure room, use it. Use it as soon as you suspect. The very first person in your organization who measles crosses their mind, everybody needs to speak out and say, let's get this kid to a negative pressure room. Collect your samples. They can be sent to DCLS, which is probably where they'll go. That's VDH's lab. Or depending on where you are, commercial labs can run these for you as well. Again, it's going to be your nasal swab, maybe also a secondary pharyngeal swab, and then blood, and call your health department. Follow that WHO algorithm. Think about whether you need to admit this kid or not. Are they at high risk? Are they young? Are they pregnant? Are they immunocompromised? Do they have signs of bacterial pneumonia that worry you? Do they have signs of encephalitis or dehydration that worry you? Treat with vitamin A, and then sanitize that room and close it for 2 hours, and then sanitize it again. So let's talk a little bit about post-exposure prophylaxis. So what do we do if we get a case of measles? We talked about that. how do we shut measles down? And the answer is, first, you shut it down by having herd immunity. In the absence of herd immunity, you give secondary prophylaxis, post-exposure prophylaxis. I want to walk you through these charts. I'm not going to go, like I said, into great detail, but I just want you to have seen sort of how it works. So you really, for all ages, if you're immune, and we're going to talk about what that means in a minute, but if you're immune, then you're good. You don't do anything. There's no post-exposure prophylaxis to give. There's no quarantine. And you just tell them, listen, if you get sick in the next 21 days, be vigilant and call us type thing. Because, still 3% can get it despite being vaccinated. If you are under 6 months old, but you're immunocompetent and non-immune, you're going to have to give IVIG or IMIG to that person. And then you quarantine them for 28 days. When we had the kid in our ER, we had one kid we had to do this to. I had to call the parents and tell them, not only do you have to bring your kid to the ER for an infusion, you got to keep that kid out of daycare for 28 days. It was not, they weren't thrilled, to say the least. If it's after 6 days, it's too late for the post-exposure prophylaxis. You just quarantine and monitor. If they're older, 6 to 11 months, then you can give the MMR, which is preferred, or you can give the immunoglobulin, but really vaccination is preferred. If they get the vaccine, there's no quarantine. If they get the immunoglobulin, then there's quarantine. If it's a little later, 72 hours to 6 days, then you're kind of stuck and you got to give the immunoglobulin in quarantine. And if it's after 6 days, you're too late and quarantine. The MMR, interestingly, is safe to give after 6 months old. It's safe to give before 6 months old, but it doesn't work. Between 6 and 11 months old, it works, but immunity wanes rapidly. And so it will protect the child up until a year or so. So, but after that, it sort of wears off. So we recommend giving the dose to 6 to 11 month olds, kids who are not able to get the 12-month shot, but are older than 6 months, if they're traveling to an endemic country, or if they are in a outbreak environment. So kids in those communities in Texas that are 6 months old are all being told to go ahead and get your MMR. That MMR that you get between 6 and 11 months old doesn't count for the primary series. So you still need 2 shots after a year to get your 97% immunity, but it will protect you in those months. If you're older than 12 months and you're not pregnant and you're not immunocompromised, it depends on your vaccine status. So if you're non-immune, give the MMR and then no quarantine and you're fine. If it's longer than 3 days, then you're stuck giving the immunoglobulin and quarantine. If you've gotten 1 dose of the MMR, you give your second dose. If you're an unknown immune status, you just go ahead and give MMR. Excuse me. Pregnant women that are immune, even for a pregnant woman, PEP isn't indicated. If they're non-immune or IgG negative, you give the IVIG. And if it's unknown, you can try and draw immunoglobulin titers to determine immunity, but actually in reality, they don't come back quick enough for that really to help you. So you're probably going to end up giving IVIG. And if you're severely immunocompromised, you give the IVIG. So let me stop there. And any questions so far? Okay. So
wait, we just had one hop on. Hold on just a second.
Sure.
Okay, this is from Dr. McIntosh. Says, good evening, everyone. Excellent presentation with much needed updates, Dr. Donowitz. Are you concerned that there may be a possibility that this nation's measles elimination status could be lost with the increasing anti-vaccine sentiments, not only in Texas, but increasingly across the US? Thanks.
Absolutely. Yeah, vaccine hesitancy is a problem. And, you know, we can talk about it. I don't want to get into politics too much tonight because there's 93 people on the line and I disagree with somebody. But the fact of the matter is you know, with what we've seen in the last month with the ACIP being replaced, you know, the group of folks who are sitting on that council at the minute are not qualified to make recommendations on vaccine on whether we should be giving children the vaccine or not. So far from their first meeting, their recommendations were rather mild. You know, they said we should take thimerosal out of vaccines. It's out of most vaccines anyway, even though it was not shown to cause autism. It's pretty much gone anyway. So they were kind of these mild recommendations. But certainly there's worry that we may end up in a place where the recommendations for vaccinations and routine vaccinations shift. The real question is going to be when the insurance companies sit down to do their math, are they going to decide that it's cheaper to pay for these vaccines, or is it cheaper to pay for the fallout of not having these vaccines? I haven't done that math. I wouldn't know where to start, but my hope is that when they do it, they find the vaccines the cheaper option, and these remain available in the United States to everybody who wants one. I think if insurance companies aren't paying for them, we're going to see an absolute decline across the board. I think at the moment, vaccine hesitancy in and of itself, in a climate where folks can get who you know, people have access, they just don't want it. It's, you know, vaccine hesitancy is a growing problem, but it's a pocket problem, right? So it's not every community is at risk. You know, we had the one case that came through Charlottesville. We had a second case that was a direct exposure to that first case, and then it was shut down. And we haven't had a case since, knock on wood. And that's due to local vaccination rates. So are we going to lose our status as a nation? Maybe, depending on where things go. Certainly cases are rising to sort of historically high levels in post-vaccine era. But I am more worried about what happens if we start losing access for people.
So Dr. Donowitz, there's another question I'm going to read to you. Would you advise parents with children under the age of 1 to reconsider flying to areas of high transmission?
No, I would encourage them to just, well, so back up. Under 6 months, yes, I would absolutely tell them to reconsider. I would not take my 6-month-old to Texas right now. You know, I would not take my 6-month-old to countries. I do a lot of international travel for science. I would not take a 6-month-old to countries that are endemic. Between 6 months and a year, I would just vaccinate that kid. I would get them their MMR early. It won't count. It'll be an extra dose, but that child's protected, and then, you know, go on your trip type thing.
Okay, that's it for now.
Awesome. So let's talk about vaccine hesitancy. Let's talk about, you know, I think it has become really easy, sort of going back to the Peanuts, you know, strip here. You know, it's very easy to be Lucy, right? It's very easy just to scream, "That's so stupid. Vaccines are safe. Why are you so stupid?" And get very frustrated with vaccine hesitant people when you come from where I come from, which is obviously a sort of pro-vaccine infectious disease background. And during my training and when I was a younger man, I probably had more of this in me. As I have gotten older and I've met more families, and I've met families of kids with vaccine preventable diseases that are in our intensive care unit with vaccine preventable diseases. I've seen 3 cases of neonatal pertussis in our ICU this year. So as I've met these families, I think just screaming, "How can you be so silly?" is not, A, it doesn't work, and B, it lacks understanding in what's driving this process. So what current studies have shown are that really what we're dealing with is an issue of cognitive dissonance. So this trial that I have up on the screen, it was published in Pediatrics, really one of my favorites. And what they did here was they took folks who had sort of vaccine hesitancy, and they tried different things to around the MMR in terms of messaging, including things like showing them pictures of kids devastated by measles. And what they found is that actually those type of messages where you're showing kids, showing the end stage disease and the worst case scenarios and those type of things, they actually caused people to become more vaccine hesitant than less vaccine hesitant. That study is a great read, by the way, a real nice piece of science. So what are sort of the common reasons that families give for vaccine hesitancy? So medical distrust. This thought that the drug companies are trying to just make money, true. But that transmits down to their PCP and their doctor's offices and those type of things. And really, it's just, I think people are in it for the money. Too many at a time, right? That this is going to overwhelm my kid's immune system, or that it's going to weaken the immune system. Religious objections. So some of these are, sort of based on religious doctrine, but really the only religious doctrine that is sort of says you can't have vaccines are Christian Scientists and Dutch Reform. The other major religious communities have come out, and said we believe vaccines to be appropriate for our congregants type thing. There is some concern about components, right? So there are vaccines that have bovine components. There are vaccines that have porcine components, so Jews and Muslims. And then there are some vaccines that are made with fetal stem cells that Christians have been concerned about. I mean, I think it's worth stating, and the way that Pope Benedict, before he was Pope, came out and he sort of led the Catholic meeting and sort of dogma on this, which really said so these stem cells are perpetuated. They're not from new abortions. They're from elective abortions that took place, decades ago, and the cells are propagated. And he basically said that it was a sin to abort those fetuses and perform those abortions, but this far out, using those cells or vaccinating your child with the product of those cells or science that came from those cells is not a sin. And then misinformation, obviously, and fear come into this a lot. So what we see out of these is cognitive dissonance. And that's really where we get to. So what is cognitive dissonance? Cognitive dissonance is when a person holds 2 or more conflicting beliefs or values or identities, and this causes discomfort. These 2 things can't exist together. And the mind seeks to reduce that discomfort. And usually what it does is it tries to justify something that doesn't fully make sense or in some way. So how does this actually work? So most of the parents that I have met that have anti-vaccine beliefs are actually rational people, well-informed people. Many of them are educated. And all of them, every single one has wanted the best for their child. I have never met a malignant anti-vax person who wanted to do their child harm. So you know, and this is just an example, but you get a person like that, and part of this anti-vaccine becomes part of their core self-image. This is who I am. I believe this. And then there's a belief that vaccines cause autism. And I'm throwing that out there, but obviously it could have been anything from the previous slide, right? So then we come in with medical facts, right? If I sit this person down and I show them those two papers I showed you and said, look, vaccines don't cause autism, and Wakefield made it all up, that causes discomfort in these people. These medical facts don't, if I believe them, and I believe Wakefield made it up, and I believe my pediatrician, this doesn't jive with what I believe in my self-identity, and that makes me uncomfortable. And so what does the mind do in that situation? It seeks to put these things in harmony. So discredit the science, right? Who's funding that study? Why do I trust that science? Embrace alternative narratives, or conflate vaccination with institutions, right? So I really don't trust drug companies. You know, so I these come from drug companies, so I'm not going to trust you either, right? And they're going to come up with some other way for this to make sense. So then we get into what we call the cycle of belief perseverance. How does this belief that vaccines cause autism, or any of the other beliefs we showed, sort of stay alive in the face of conflicting data? So people have a lot of emotional investment. Many of these people have tried to do their own research. They've read for hours and hours. They've been in chat rooms, talked to other parents. They've listened to podcasts, whatever. They're really emotionally invested in what they believe. There's confirmation bias. So confirmation bias is a huge problem these days. And part of the problem is the internet. So you can go to Reddit, or you can go to Facebook, or you can go to any echo chamber that you like, and you can find lots of stories of a kid who got their MMR and 3 days later went from being normal to being autistic. And it just happened overnight. Stop talking and those type of things. There are a couple of interesting papers that out there that I don't show, but that actually discuss that these type of posts have been traced back to known foreign actors, particularly Russian, that are sort of sowing disinformation, in these social media spaces. But even without the foreign actors sort of poking the bear, so to speak, it is not hard to surround yourself with people that have similar beliefs as you, to find stories on the internet, whether that are clearly not true, but people are posting them, and you read them and you go, oh my gosh, that could be me. Social reinforcement, again, very difficult when your social circle is an internet chat room and not real people around you. And then finally is there's a real sunken cost and public commitment. Many of these people have been very vocal about their beliefs, and to change their beliefs would come with social cost. So sort of how does this cognitive dissonance thing work? Here are a couple just examples. The dissonance trigger: scientific evidence contradicts their personal beliefs. Vaccines work, and I think they're dangerous, so I'm going to discredit or distrust the science. I'm a good parent, but I'm going to refuse to vaccinate. So good parents vaccinate versus, I won't vaccinate. Let's redefine what a good parent means. I'm only going to do natural things for my child, which interestingly enough, anytime I've heard that, I've made the argument that vaccination is the most natural form of immunity out there. There is nothing more natural than harnessing your own body's immune system to protect itself. Sort of the public anti-vax stance versus new information. You double down to avoid the shame of going back on what you had once said. Trust in science versus mistrust in institutions, right? I trust my doctor. I trust UVA, but I don't trust Big Pharma or the CDC. Maybe that distrust starts to extend to medical experts as well to make it so you can sort of tolerate this. So this is sort of a map of vaccine hesitancy in the US. This was published in 22. And really just what I want you to take away from it, don't pay too much attention to the individual states or localities, but vaccine hesitancy is a regional problem, right? So, and you can see certain states that have widely disparate pockets of very vaccine hesitant people and really, very low rates of vaccine hesitancy. So this is a community level issue. So just to give you the timeline, I really like this article in the New England Journal, the vaccine hesitant moment. Just to sort of give you the timeline of how we've seen vaccine hesitancy increase. It was 98 when the Lancet published its Wakefield paper. And on the heels of that, people got really worried, despite the fact that Wakefield argued that it was due to replication of the measles virus in the gut. This thing got sort of a life of its own, and there was this anxiety around thimerosal and its link to autism, this mercury derivative that was used in vaccines. And in 1999, the AAP argued that thimerosal should be removed from childhood vaccines, which for the most part it was. Google came about in 1998. I know some of the younger folks can't even believe that's true, but it is. Facebook, YouTube, Twitter, all in the sort of early 2000s. The HPV vaccine in 2006. We had the H1N1 pandemic in 2009. Instagram later, Snapchat later, TikTok later. I don't even know what Telegram is. Somebody else may know. And then it wasn't, until sort of the global measles outbreak, because we're not the only country with vaccine hesitancy in 2019. And then obviously the COVID-19 pandemic and the COVID-19 vaccine rollouts and the debate around the safety of those rollouts and everything that happened there did not help vaccine hesitancy. When I was training, sort of in the 20, I became a doctor in 2010. Most of the vaccine hesitancy I saw was MMR specific. But these days it's sort of broadened past just this sort of thimerosal issue. So how do you combat this cognitive dissonance? It's hard, is the answer. Couple of strategies and things to think about. And I don't have a magic bullet, unfortunately, for this. But some things to think about. Peers are more persuasive than authorities. If there are trusted community leaders or trusted peers that you can enlist in your community, if vaccine hesitancy is a big deal in your community, enlist those people. The obstacle, many times peers are behind a computer screen online and not maybe real people or not. Also, make yourself human. Sometimes we set up a wall behind our white coats, and you're going to do a lot better in these discussions if you take off the white coat and look people in the eye. Reduce the threat, increase dialogue, focus not on facts, focus on values. What led people to believe that? What are your values around vaccines? Frame the issue in a way that aligns with their existing values. Protecting your family and community and trusting science, a lot of people can get behind. Instead of facts, provide narratives. Humans are actually hardwired for narratives, not statistics. Normalize changing beliefs. You got to give people a dignified exit from this path that they've walked down, right? Help them save face. Make the idea that we can change our views on important things in the face of new evidence common. Tell stories about people who have done that. Share the fact that in these communities in Texas where there's an outbreak, vaccination rates have gone through the roof. And we saw that even in Charlottesville when we had a single case come through town. Our clinics were mobbed on Monday with people who had changed their mind on this. Normalize that. And then slow incremental shifts work best. So take home points, never be afraid to phone a friend. That phone number on the screen is to the operator at UVA, and any provider in the state can ask for PEDS ID physician on call, and they will page us 24/7. We are happy to help you think through things. The AAP Red Book, phenomenal resource. The CDC websites are still reliable as of today. Some pages have been taken down or altered, but generally what's up there is still reliable. Treat the patient and prevent transmission. Protect yourself, protect your staff, limit healthcare exposures, and familiarize yourself with post-exposure prophylaxis on the VDH website. And all of this is preventable with very safe vaccines. So I always end my talks with a quote from the Dr. Osler. Much more important to know what sort of patient has a disease than what sort of disease a patient has. And I will stop there and happy to take questions if there are any.
Okay, we do have a question. This is from Dr. Dupre. Instead of MMR, is it possible to get measles, mumps, and rubella vaccinations given separately?
It is, but more difficult to obtain. But they exist.
Okay, thank you.
Yeah, that's generally more of a process question. They're out there, but more difficult to attain, not cost effective, those type of things.
Other
Okay.
questions, Mary? Do we have others in the,
No, that's it.
are there any on the line? Anyone else have a question for Dr. Donowitz? Dr. Donowitz, I want to ask you a quick one. When you mentioned the late occurring complications, subacute sclerosing, I think, and encephalitis when the child presents with learning disability, how do you diagnose that? I mean, is that an MRI diagnosis? Is there anything objective? Sounds like that would be hard to nail down.
Yeah, so it's a good question. I've never seen it myself. I believe there are characteristic MRI findings, but I'd have to go back. I'd have to go back and read on that. That's a good question.
Okay. Any other questions from anyone on the call? We're running a little late, but it's been an excellent topic. So contemporary and so relative. And I know the ones of you on the call today are predominantly primary care, and you're seeing these children all the time, and I know you have parental conversations, so hopefully this can be helpful. Final call, any questions? Dr. Donowitz, thank you again for your superb presentation. We hope everyone will join us again in 2 weeks when we'll talk about local resources for patients and how to determine capacity of individual patients to make healthcare decisions for themselves. I hope you'll join us. As I remind our residents, when I have the privilege of talking and teaching with them, please be careful out there. And we hope to see everyone back in a couple of weeks. Thanks for being with us. Have a great evening. Try to stay cool. Bye-bye. Good evening.
Thank you all so much.